So CO2 and pH and oxygen, these are not the only factors that change your respiratory rate or your minute ventilation. Um, your respiratory rate is also changed directly just by proprioceptors. Proprioceptors are a special type of mechanoreceptor that are constantly reporting to the central nervous system what position your limbs are in space. Like when you close your eyes, if someone moves your leg, you know where your leg is, right? But also how much your limbs and joints are moving. That means that the proprioceptors will be informing your central nervous system that you are racing to try and catch a bus before CO2 levels start to build up in your bloodstream. So you will start to breathe faster earlier because of your proprioceptors. You can, of course, voluntarily change your rate of breathing. If I asked you to breathe twice as many times per minute, you could do that. Anxiety and fear and anger will also make us breathe more quickly. And that's why your respiratory rate is one of those things that people doing lie detector tests will measure. Increasing your body temperature will also increase your respiratory rate a little bit. Pain will also increase respiratory rate. In the veterinary hospital, it is sometimes difficult for us to know if the animals in our care are experiencing pain. Certainly, if you suddenly hurt them, like clip their toenail too short, they will yell out. But with chronic pain, like bad abdominal pain or serious headache kind of pain, those are things that animals do not cry out for, not even dogs. And so, how do we know if we are giving them enough painkiller? We will monitor their respiratory rate and their heart rate. Irritant receptors, if something gets stuck in your trachea, you will cough and increase your respiratory rate until it is gone. And then also stretch receptors. It is possible for you to breathe into the lungs to do CPR breathing in an unconscious patient, but you can't do that in a conscious patient. Go ahead, give it a try with one of your best buddies because they will start to cough right away. Let's talk a little bit more about breathing. And gosh darn it, this is not an intuitive concept. It's not hard to grasp. It's just not the way we usually think of as breathing. The lungs work because air gets pulled into them with suction, right? So it's just like this. You probably already know this, that when your diaphragm is in its, which by the way is skeletal muscle, that's why it needs a command from the medulla to contract. When your diaphragm is in its relaxed position and it's all like, ooh, relaxed, it goes into this domed up position. I don't understand all the mechanics of how it does that, but that is how it would be in position. When this muscle contracts, it shortens, and when it shortens, it will pull down. That means that when the diaphragm is in the relaxed position, the space of the thoracic cavity is smaller than when the diaphragm has contracted, right? When the diaphragm contracts, it expands the size of the thoracic space, and that will create a negative pressure inside of the alveoli. And that relative vacuum inside the little airways compared to atmospheric is what pulls air into the lungs. Here's why this is relevant right now. One of our interventions for helping people survive COVID is to put them on a breathing machine. And it is naive of any of us to think that a machine that is using the opposite mechanical strategy to breathe is going to create an optimum outcome. Breathing machines, and this is true even when you've got your patient on anesthesia, they force air into the lungs. And that will have a traumatizing impact on the airways and on the alveoli themselves. Okay, so imagine that you are here and you are a little bronchiole living inside the lungs. Okay, the reason that air goes into you is because a vacuum gets created, a vacuum, and that sucks air in, right? So there is no direct expansive force on you. However, when we start ventilating people, we are pushing air in, and every time we do that, there's a little bit of stretching of all of the airways, and that just causes just the teensiest bit of trauma if you've got it dialed just right. But the more resistance there is to ventilating because your patient has got COVID-19 and there's inflammatory changes and scarring changes and stuff like that, you need more pressure to ventilate them. So there's more and more pressure, which is causing more and more damage. And this is only one of the reasons why it is very difficult once you get people on a ventilator to be able to wean them off. Okay. So let's go into a little bit more detail. Now, there are 3 different pressures that are demonstrated here. 3 different pressures. The intrapleural pressure is the pressure in this space, like right there, right there. That's the intrapleural pressure. That is the amount of pressure that would be measured in the area between the coating of the lung and the inside coating of the chest cavity. And as I told you before, it is always negative. And it's that negative intrapleural pressure that is pressing the lung up against the inside of your rib cage. The lung is not attached to the inside of the rib cage. The intrapulmonary pressure. This is the pressure that is being changed by the contraction and relaxation of the diaphragm. Okay, that is that pressure. And the transpulmonary pressure, that's from the outside to the inside going in. Now, these are the 2 that from our point of view are most important. So I wanted to show you some x-rays. I like radiology, so I should have done that. Anyway, this is an x-ray of what your lungs look like when you've exhaled completely. And you can see here, we have got the line of the diaphragm. The human liver is sitting right there. The human stomach sitting right there. And see that little bubble of gas right there and there? A little bit of gas in your stomach, okay? This is the silhouette of the heart. And you can see that the heart cannot be clearly visualized when the patient has fully exhaled, right? Because everything gets loaded up. If you really want to see the size and shape of the heart, you need a good inhaling view so that the heart is surrounded by the air-filled structures, which are the lungs. Okay? When you have fully exhaled, that little end of your lung is right there at like rib number 7. And then, but when you fully inhale, as the lungs expand, it goes all the way down to there, right? So the lung slides down the inside of the rib cage, slides back up the inside of the rib cage, back and forth, back and forth, back and forth, right? It is allowed to slide forward and back because the lung is not attached to the inside of the thoracic cavity and because there is that pleural space that always has a negative pressure and is filled with just a little tiny bit of slippery fluid. That's called pleural fluid, good name for it, right? The pleura are serous membranes. There is one layer of pleura that lines the inside of your rib cage, one layer that lines the outside of your lungs, and they do have sensory receptors in them. So when a virus or something else causes an inflammation of the pleura, you get a condition that is called pleurisy. In human medicine, it's called pleuritis in veterinary medicine. And it's an inflammation of the pleura, and it will be experienced as pain when you inhale, or sometimes with the pain, a sandpapery feeling as you breathe. All right, we are going to start here at the beginning of our next video.